Renal vein thrombosis was first described by Rayer in 1873. Kaufman collected 96 cases occurring in childhood since the year 1900. McFarland in 1965 described 36 patients. Beck and Marshall in 1968 reviewed 40 patients in whom a diagnosis had been made during life. McDonald described 24 patients in 1974. And in the last 20 years, sonography, computer tomography, magnetic resonance imaging, and angiographic examinations have demonstrated the ability of these non-invasive and imaging techniques in demonstrating the presence of renal vein thrombosis. There are many causes of renal vein thrombosis. Malignancies in adults should always be kept in mind, and they can be due to a hypernephroma or renal cell carcinoma. Carcinoma of the pancreas, particularly the left kidney, can cause invasion of the left renal vein and be the cause of a left renal vein thrombosis. A retroperitoneal malignancy, metastatic disease to retroperitoneal nodes with secondary invasion of the veins. All of these are possibilities. In children, we shall discuss later, particularly severe dehydration, babies from diabetic mothers, babies with diarrhea, the 3 Ds, dehydration, diabetes, and diarrhea. Inferior vena cava thrombosis propagating into the renal veins is not uncommon, particularly when there is a thrombophlebitis of the pelvic veins or the veins of the lower extremities. Polyarteritis nodosa can cause renal vein thrombosis. Heart failure, injuries to the abdomen, or surgical trauma to the retroperitoneum, and interestingly, medical nephropathies, such as membranous glomerulonephritis, perinephritis, papillary necrosis, and amyloidosis. High probability situations for renal vein thrombosis include the presence of a renal cancer, abdominal trauma, membranous glomerulonephritis, or other nephropathies in patients who have unexplained decreased renal function, acute idiopathic non-obstructive renal failure, and renal allografts with unexplained deterioration of transplant function. The morphological staging of renal vein thrombosis, correlating rate and type of occlusion with development of collateral venous drainage and renal response, is as follows. The renal vein thrombosis can be acute or chronic. When we say chronic, we mean gradual. The acute form is complete or incomplete, and if there is an acute complete obstruction, we have to expect edema of the kidney, that is a marked congestion, and the marked congestion is manifested by a lack of function, be that adult or a child with a swollen kidney that does not excrete contrast, and with a non-dilated pelvic-calyceal system is almost pathognomonic of renal vein thrombosis. This marked congestion can rupture the kidney and lead to retroperitoneal hemorrhage or lead to hemorrhagic infarction, and the late sequela is atrophy of the involved portion of the kidney. Incomplete acute obstructions lead to mild congestion, and this results also in poor function. The mild congestion can be seen accompanied by venous collateralization and return to good function, that is reversible of the process. The gradual obstruction, or so-called chronic renal vein thrombosis, can be complete or incomplete. We will always see expansion of the perirenal veins, that is a venous collateralization. And this is why the kidney will not enlarge or become atrophic, and why function will be preserved due to the effectiveness of the venous collateral circulation. So there will be little or no congestion, and structure and function will appear normal. Clinically, if there is a sudden occlusion of the renal vein, edema of the kidney will become manifested by severe lumbar pain. In children, particularly in infants, we may see an abdomen where the affected kidney will be palpable. Hematuria, proteinuria, and oliguria, and death from uremia will be the result of bilateral acute renal vein thrombosis. Most of the time, renal vein thrombosis, particularly in adults, is a gradual process. And as such, clinically, it will be silent. And this is because of the compensated phenomena as a result of the development of collateral circulation. However, proteinuria with or without hematuria may be observed, and the nephrotic syndrome may be a manifestation of gradual renal vein thrombosis. When the inferior vena cava is occluded as well as the renal veins, the patient may have edema of the lower extremities or lower part of the trunk, and these individuals are predisposed to pulmonary emboli, and one may see distended superficial collateral veins from the umbilicus all the way down to the pelvis. The prognosis of renal vein thrombosis will depend upon the location and extent of the venous occlusion, the rapidity of its development, the presence of other parenchymal disease, be that a tumor or of medical nephropathy, and depends also on the early diagnosis and the success of treatment. Pathologically, there may be no lesions of the kidney, and this occurs when there is a gradual occlusion and there is a collateral venous circulation. There may be hemorrhagic infarction, and this is seen particularly in children. A small contracted kidney is often associated with hypertension, and we may also see membranous thickening, that is glomerulonephritis, causing the syndrome of nephrosis, or the so-called nephrotic syndrome. Sometimes it is the membranous glomerulonephritis that precedes and not follows the renal vein thrombotic episode. Whenever we have a unilaterally enlarged, non-visualized kidney, we have to suspect certainly hydronephrosis. This will be the most common cause. We can suspect a hypernephroma. There can be diffuse inflammation of the kidney. We may have a patient with stones or without stones, but with xanthogranulomatous pyelonephritis or simple pyelonephritis. We have to consider the possibility of renal vein thrombosis, and also perirenal processes such as subcapsular hematoma. Urography may be absolutely normal. The kidneys can be normal in size. They can be enlarged, particularly in the acute phase of decompensated renal vein thrombosis due to the edema of the kidney, or eventually in chronic forms where there has been hemorrhagic infarction, the kidney will decrease in size. Again, the kidney is normal, enlarged, or small. The excretory function of the kidney depends on the mechanism of the renal vein thrombosis. We may see non-functioning kidney due to acute decompensated renal vein thrombosis, and this happens particularly in infants and children. The function of the kidney may be decreased, and we may see a delayed excretion with a poor visualization of a non-dilated pelvocalyceal system, or the function may be absolutely normal. The calyces, renal pelvis, and ureters may be normal, or they may appear stretched or compressed due to the edema of the kidney, or there may be notching, that is indentation of the outline of the renal pelvis and or ureters due to the expanded peripelvic and periureteric veins. And we may see dilated perirenal veins, particularly on computed tomography and on nephrotomography. Regrouping the signs of renal vein thrombosis based on the frequency of observation and the urographic examination of the patient, we observe notching of the renal pelvis and or ureters, the presence of enlarged perirenal veins, and extrinsic pressure on the pelvocalyceal system as the three most common urographic signs. Kidney function, normal, decrease, or absent, and kidney size, normal, enlarged, or small, are of less importance. The size and function of the kidney are less specific. And remember that the function can be normal, can be decreased, or can be absent. And the kidneys may be enlarged, may be normal in size, or may be small. This is a specimen to your left of a kidney with decompensated renal vein thrombosis. Note that the kidney is small. It has some irregularities in its contour, and there was no function from this kidney. The patient had hypertension, and the hypertension of renal origin is due to relative ischemia. If there is a complete ischemia, hypertension will not complicate the renal vein thrombosis. There must be a certain level of ischemia for the kidney to produce high levels of renin and angiotensin, etc., as a mechanism of renovascular hypertension. A coronal section of this small kidney shows hemorrhagic infarction in the lower pole. This is a young adult who presented with edema of the lower extremities and hematuria and proteinuria. A urographic examination shows that the kidneys are normal in size and they function normally and synchronously. Note, however, discrete notching along both ureters. An attempt to visualize the inferior vena cava upon injecting the right femoral vein showed extensive superficial and deep collateral circulation. The inferior vena cava was never opacified. We can also see opacification of the portal vein. This patient was a drug addict and he ran out of veins in the upper extremities, was injecting himself in the lower extremities, and this led to thrombophlebitis. The phlebitis progressed into the iliac veins and from there into the inferior vena cava. We saw at post complete occlusion of the inferior vena cava and of both renal veins. Another image of the venogram shows huge ascending lumbar veins, opacification of the portal vein, opacification of the vertebral venous plexus, and this patient, despite having total occlusion of the inferior vena cava and renal veins, the kidneys never change in size or function because the occlusion of the renal veins occurred slowly. So blood got in via the renal arteries and departed via anastomosis between the intrarenal veins and the perirenal venous circulation. And from there, it went into the portal system and into the systemic circulation. That's why this patient never had deterioration of renal function, despite that post-mortem revealing the presence of total obstruction of both renal veins. This patient is a 68-year-old man who had histologically proven membranous glomerulonephritis. Clinically, he suffered of the nephrotic syndrome. Suddenly, there was deterioration in renal function, and a repeated urogram revealed poor function of the two kidneys with very small pelvocalyceal systems, and there was a very discrete notching of the ureters. These findings were overlooked by the radiologists who interpreted this study. Repeat urographic examination with tomograms showed that the two ureters had notches due to dilated periureteric veins, as we shall discuss later. At another institution, a selective left renal arteriographic examination was interpreted as negative. However, note that following the parenchymal phase, we do not see opacification of the renal veins. Retrospectively, this should have been considered an indirect sign of renal vein thrombosis. A renal biopsy revealed all the signs of membranous glomerulonephritis. Electron microscopy revealed the dense material and the foot processes also described with membranous glomerulonephritis. In another patient, immunofluorescence was observed at the glomeruli, which is characteristic of the deposition of anti-gamma globulin proteins. In this patient, we did an inferior vena cavogram. And note that there is a very extensive filling defect at the entrance of the renal veins and occupying the hepatic segment of the inferior vena cava. Note the absence of streaming of unopacified blood that should be seen in a normal examination. This is pathognomonic of inferior vena cava obstruction with renal vein thrombosis. At surgery, the inferior vena cava was found to be filled with thrombi that extended from the renal veins into the inferior vena cava. The surgeon proceeded with a thrombectomy and also relieved the obstruction of the renal veins. Immediately after surgery, there is a massive proteinuria, and the patient gets worse. However, the renal function slowly returned to a baseline, and the consequence of renal vein thrombosis was deterioration of the abnormalities secondary to membranous glomerulonephritis. So a patient who has deterioration of renal function, one should look for associated renal vein thrombosis, which when present not only will deteriorate renal function, but will predispose the patient to pulmonary emboli. These are two patients with renal vein thrombosis associated with medical nephropathies. Both were inferior vena cavograms, revealing the presence of extensive filling defects due to thrombi. And again, note the absence of the streaming effect that should be seen as unopacified blood from the renal veins enters the lateral walls of the inferior vena cava. This patient with amyloidosis shows the presence of thrombi in the renal veins, and on one side the thrombi protrude into the inferior vena cava. Causes of renal vein thrombosis due to medical nephropathies include glomerulonephritis, both the membranous and the membranoproliferative form of glomerulonephritis, rhinosarcoidosis, amyloidosis, lupus nephritis, sickle cell anemia, and Goodpasture syndrome, which is the so-called pulmonary renal hemorrhagic syndrome. The pathogenesis of renal vein thrombosis in membranous glomerulonephritis is either a hypercoagulable state from increased platelets and fibrinogens, or from serum antithrombin, that is a decrease in the blood. It can be also due to hyperviscosity of the blood, to hemostasis, that is slow circulation, or to venous intimal injury. This is a young medical student who presented with hematuria. An intravenous urogram was obtained, and the clinical diagnosis was perhaps obstructive uropathy due to a renal stone. The IVP revealed extrinsic pressure on the left renal pelvis and discrete notches of the proximal left ureter. There was no evidence of a ureteral stone. We performed a selective left renal arteriogram, injecting the two renal arteries supplying the left kidney. In the venous phase, note that there is no visualization of the renal veins. Some collateral venous channels are noted caudal to the kidney, and observe that dilated veins are seen in the hilus of the left kidney and were the cause of the extrinsic compression of the inferior margin of the left renal pelvis. So this is an example of silent left renal vein thrombosis. This is a close-up of the left renal sinus in this patient with silent left renal vein thrombosis. Note the dilated peripelvic and periureteric veins, which explains the extrinsic pressure on the lower aspect of the left renal pelvis. Silent renal vein thrombosis may reveal nothing in the urinalysis or hematuria or proteinuria. And what is important is to recognize left or right renal vein thrombosis in patients who may not have any organic lesion of the excretory system of the kidneys, and that the hematuria is coming from the renal parenchyma or from ruptured submucosal venules due to the congestion that exists around the renal pelvis or around the ureter. This is a child who presented with left flank pain and a palpable kidney. Note the poor visualization of a small left pelvocalyceal system and enlarged left kidney. A selective left renal arteriogram showed in the arterial phase some spreading of the arteries, which appeared slightly narrowed, but there was no focal mass in the left kidney. In the parenchymal phase, we see uniform opacification of the renal parenchyma of this enlarged left kidney, and there was no visualization of the renal veins when the study was prolonged. So this is another example of a left renal vein thrombosis manifested by lack of visualization of the left renal vein. "40% of all cases of renal vein thrombosis occur in infants. There is often a history of the 3Ds, which are dehydration, diarrhea, and maternal diabetes. 2/3 occur in the first 2 months of life, and nearly all occur under 2 years of life." Non-invasive imaging modalities for the diagnosis of renal vein thrombosis include sonography, computed tomography, isotopic examination of the kidneys, and magnetic resonance imaging. A baby had a palpable left kidney and proteinuria, as well as hematuria. Echographic examination of the left kidney revealed echogenic areas scattered through the kidney, which appeared enlarged, and also echoes coming from an enlarged left adrenal gland. Repeat echographic examination revealed the resolution of the adrenal hemorrhage and also a return to an almost normal size and echogenicity of the left kidney. This baby had an episode of left renal vein thrombosis, which was a reversible situation. An isotopic study of the kidneys revealed the photopenic area at the level of the left adrenal gland and decreased uptake at the level of the left kidney. Echographic examination of a child with renal vein thrombosis revealed in the affected kidney the hyperechoic interlobular streaks, which are very suggestive of this complication. Below, one can see the contralateral normal kidney with normal echogenicity in contrast with the speckled echogenicity of the affected kidney. In this other infant, and we're showing example of perinatal renal vein thrombosis, the right kidney in the sagittal projection shows loss of the corticomedullary differentiation and echogenicity in the form of striations, as well as enlargement of the kidney. All these are suggestive findings of renal vein thrombosis. There was a thrombus in the inferior vena cava, as indicated by the arrow. In this CT examination, one can see the enlarged right kidney with increased concentration of the contrast material, and note that there is enlargement of the right renal vein and of the inferior vena cava. A typical whiskering effect of the renal fascia is observed. In this left kidney, note a prolonged opacification, and that the left renal vein appears distended, and there is a large thrombus within it. Note in this patient with a carcinoma of the right kidney, which extended into the right renal vein, and there is therefore a mass within the right renal vein and inferior vena cava, the concordance in the imaging findings. To your left is the CT and to your right the MRI. The MRI distinctly reveals tumor invasion of the inferior vena cava, which corresponds to the same findings in the CT examination. Similarly, in this next patient with a carcinoma of the right kidney, Note the CT examination to your left, which shows an apparent mass in the hilus of the right kidney, which was suspected to represent a neoplastic extension or associated thrombosis of the right renal vein. However, the MR examination shows that the inferior vena cava and both renal veins are patent. So we can see, therefore, that the MR examination is more helpful to show patency of the veins, and that on CT examination, a mass at the level of the hilus not always represents dilated vein. And the MR examination, by showing the lumen of the vessel, is more specific than CT in the diagnosis of renal vein thrombosis. The angiographic findings in renal vein thrombosis can be divided in the arterial and in the venous phase of the study. The renal arteriogram may show a normal arterial phase, or the arteries may be stretched and or compressed. There may be flow retardation, and the renal veins may not be visualized or may reveal the presence of filling defects. We may see collateral veins surrounding the kidney, around the renal pelvis, in the retroperitoneum, and surrounding the ureters. The phlebographic examination may show the occluded renal vein and or the inferior vena cava with the pathognomonic sign, which are the filling defects in the renal vein and or in the inferior vena cava as well. There may be a patent inferior vena cava, but there will be lack of the negative defect caused by unopacified renal venous blood returning towards the inferior vena cava. And collateral veins are usually demonstrated.